Hello, everyone, and thank you for tuning in for VNAA's overview of the emergency preparedness regulations for both home health and hospice. My name is Joy Cameron. I'm the Vice President of Policy and Innovation for VNAA, and we are going to look at the regulations that were just made effective on November 16th of 2016. Just as a note, you have until November 16th of 2017 to comply and implement all of the emergency preparedness regulations. However, there are some processes that will take you some time, so it is best to get started as soon as possible. So with that, we're just going to discuss home health and the risk assessment and planning, policies and procedures, communication, and training and testing that are required by this regulation for home health. Then we're going to look at the hospice side of the house and review risk assessment and planning, policies, procedures, communications, training, and testing. But then I will also do a brief portion of discussing clarification so you understand some, if you were to look at the regs themselves, some of the questions, common questions and concerns that are out there about this rule. As always, and with this and anything else, if you have any questions or concerns and want to get in touch with us, our contact information is on the website, but the last slide of this presentation also has my direct contact information. So with that, I'm going to go ahead and get started with the home health section. So just as an overall looking at things, these rules do require an all risks assessment, a comprehensive plan to address those risks, along with a periodic plan update, policies and procedures to implement that plan and have them available, ongoing training of all staff, communication plans, training and staff drills to implement and test the plan. Also, this rule was developed by identifying first new conditions that required hospitals to comply, and then applying very similar rules with subcontractors or additions for each provider type. So now that they've developed the hospitals, they are extrapolating it out for both home health and hospice. There are separate rules laid out for both home health agencies and for hospices, as well as some additional rules for hospices with inpatient facilities, and we do touch on that in that section. They suggest that to fully understand the rule, you should both familiarize yourself with the regulations, but also become familiar with the explanatory material for the hospital's conditions of participation. I know that's an extra step and seems a little incongruent with we are home health or we are hospice, but what they want to do is make sure you understand the spirit and the sense of this new regulation. CMS has estimated it will only take a home health agency 26 hours at about $1,424 to develop its comprehensive risk assessment and emergency preparedness plan, and about 80 hours total to do everything that the regulation will require you to do. Of course, there is no additional funding forthcoming from CMS, but again, they encourage an adoption of a well-thought-out, cohesive system of response both within and across provider types. So that's especially important for our systems members as well as those that work in bundling financing structures that allow you to coordinate with other types of provider types. So it'll be important for you to consider that when you're going forward. So again, we're going to cover risk assessment and planning, policies and procedures, communication, and training and testing. While there are requirements for home health and hospices that are very similar, there are some differences, and while some are clearly intentional, others may be unintentional artifacts of the writing and editing process. CMS also notes that some disaster preparedness activity is already in the hospice conditions of participation, but not in home health conditions of participation. Hospices that include inpatient facilities will need to meet additional conditions related to inpatient facilities. Special conditions for hospices with inpatient facilities are in the hospice summary. And with regard to home health, CMS asserts that the JCAHO, the Joint Commission on Accreditation of Home Care Organizations, accredited home health agencies already must comply with standards related to emergency preparedness, and will thus have a somewhat lower burden in complying with these additional standards. So those folks already have a leg up on this. So with that, the home health agency must comply with all applicable federal and state emergency preparedness requirements. The home health agency must establish and maintain an emergency preparedness program that meets the requirements, which must also must include, but is not limited to, these following elements. Within your risk assessment planning, agencies must develop and maintain an emergency preparedness plan and review and update it at least annually. The plan has to be based on and include documented facility-based and community-based assessment using an all-hazards approach. The plan must include strategies for addressing emergency events from the risk assessment. A note to those who live in areas that often have weather-related emergency events such as tornadoes or hurricanes or blizzards or earthquakes. I'm trying to think of all the regions of the country. That is something that has to be considered within your emergency events risk assessment. The plan must address the patient population included but not limited to the types of services the agency can provide in emergency: continuity of operations, delegations of authority, succession plans, etc. There also needs to be a process and cooperation for collaboration with local, tribal, regional, state, and federal emergency preparedness officials' efforts to ensure an integrated approach in a disaster. There must include documentation of the agency's efforts to contact such officials and, when applicable, participation in collaborative and cooperative planning efforts. Going on to the policies and procedures, agencies must develop and implement, review, and update annually emergency preparedness policies and procedures based on the plan, risk assessment, and communication plan. The policies and procedures must address, at a minimum, again, plans for patients during the disaster. Individual plans must be included in each patient's comprehensive patient assessment. There need to also be procedures to inform state and local emergency preparedness officials about patients in need of evacuation from their residence at any time due to an emergency situation based on the patient's medical and psychiatric condition as well as their home environment. A system to track the location of staff and patients both during and after the emergency. A system of medical documentation that preserves information, confidentiality is secure and readily available. The use of volunteers or other emergency staffing strategies, including state or federally designated healthcare professionals to address surge needs during an emergency, and the development of arrangements with other home health agencies or providers to receive patients in the event of limitations or cessation of operations to assure continuity of patient services. So going forward, communication. Agencies must develop and maintain, review, and update annually an emergency communications plan that complies with federal and state law. It must contain the following: name, contact information for staff, entities providing services under arrangement, patient, physicians, other home health agencies, and volunteers. Contact information for those federal, state, tribal, regional, or local emergency preparedness staff and other sources of assistance. Primary and alternative means for communication with your home health agency staff as well as those that you would work with, federal, state, tribal, and local emergency management agencies. Method of sharing information and medical documentation for patients under care and as necessary with other healthcare providers to assure continuity of care. Means of providing information about the patient's general condition and location as permitted under HIPAA, and means of providing information about the home health agency's needs and its ability to provide assistance to the authority having jurisdiction, incident command center, or designee. And finally, for home health agencies, the training and testing section, agencies must develop and maintain, review, and update annually an emergency preparedness training and testing program that must include an initial training in emergency preparedness policies and procedures to new and existing staff, that includes individuals providing services under arrangement, volunteers, and consistent with their expected roles. Provide preparedness training at least annually for ongoing staff. Maintain documentation of the training. Ensure that all staff can demonstrate knowledge of the emergency procedures. Conduct drills and exercise to test the plan, including participation in a community mock disaster drill at least annually, or facility-based drill if the community-based one is not available. This is subject to a 1-year exception if the disaster plan is actually implemented. Conduct a paper-based tabletop exercise at least annually. This tabletop exercise is a group discussion led by a facilitator using a narrated, clinically relevant emergency scenario and a set of problem statements, directed messages, or prepared questions designed to challenge an emergency plan. And then also you must analyze the home health agency's response to and maintain documentation of all drills, tabletop exercises, and emergency events, and revise the plan as needed. So that is what we have for home health agencies. Going on to hospice, these are the new rules that have for hospices, and then there will be a separate portion around inpatient hospice. So the hospice must develop and maintain an emergency preparedness plan, review, and update it at least annually. The plan must be based on and include a documented facility-based and community-based assessment using an all-hazards approach. The plan must include strategies addressing emergency events from the risk assessment, including the management of the consequences of power failures, natural disasters, and other emergencies that would affect the hospice's ability to provide care. The plan must address the patient population, including but not limited to the types of services the hospice can provide in an emergency, continuity of operations, including delegations of authority and succession plans. The plan must include a process for cooperation and collaboration with local, tribal, regional, state, and federal emergency preparedness officials' efforts to ensure an integrated approach to a disaster, including documentation of the agency's efforts to contact such officials and, when applicable, participation in collaborative and cooperative planning efforts. Hospices must develop and implement, review, and update annually emergency preparedness policies and procedures based on the plan, risk assessment, and communication plan. The policies and procedures must address at a minimum a system to track the location of hospice employees and patients in the hospice's care both during and after the emergency, procedures to inform state and local emergency preparedness officials about the patients in need of evacuation from their residences at any time to an emergency situation based on the patient's medical and psychiatric condition and their home environment, a system of medical documentation that preserves patient information, confidentiality, and is secure while readily available. The use of hospice employees in emergency and other emergency staffing strategies, including the process and role for integration of state and federally designated healthcare professionals to address surge needs during an emergency. The development of arrangements with other hospices or providers to receive patients in the event of limitations or cessation of operations to assure continuity of patient services. This section is for hospices operating inpatient facilities only. These policies and procedures must also address a means to shelter in place for patients and hospice employees who remain in the hospice, safe evacuation from the hospice, which includes consideration of care and treatment needs of evacuees, staff responsibilities, transportation, identification of evacuation location or locations, a primary and alternative means of communication with external sources of assistance. There also needs to be a provision of subsistence needs for hospice employees and patients, whether they evacuate or shelter in place, which include but are not limited to food, water, shelter, alternative sources of energy to maintain temperatures to protect the health and safety, as well as safe and sanitary storage of provisions, emergency lighting, fire detection, extinguishing, alarm systems, sewage, and waste disposal. The role of hospice under a waiver declared by the Secretary under Section 1135 of the Act, providing for the care and treatment of an alternative cafe site identified by emergency management officials. Communication. Hospices must develop and maintain, review, and update annually an emergency communications plan that complies with federal and state law. It must contain all of the following: name and contact information for hospice employees, entities providing services under the arrangement, patients, physicians, and other hospices, contact information for federal, state, tribal, regional, or local preparedness staff and other sources of assistance, primary and alternative means for communication with hospice employees, federal, state, tribal, regional, and local emergency management agencies, methods of sharing information and medical documentation for patients under hospice care, and as necessary with other healthcare providers to assure continuity of care. Means, in the case of evacuation, to release information as permitted under HIPAA, and means of providing information about the hospice's inpatient occupancy, needs, and its ability to provide assistance to the authority having jurisdiction, incident command center, or their designee. For training and testing, hospices must develop, maintain, review, and update annually an emergency preparedness training and testing program that must include the initial training and emergency preparedness policies and procedures to new and existing hospice employees and individuals providing services under the arrangement consistent with their expected roles. Ensure that all staff can demonstrate knowledge of emergency procedures. Provide emergency preparedness training at least annually. Periodically review and rehearse the emergency preparedness plan with hospice employees, including non-employee staff, with special emphasis on carrying out the procedures necessary to protect the patients and others. Maintain documentation of all emergency preparedness training. Conduct drills and exercises to test the plan, including participation in a community mock disaster drill at least annually, or facility-based drill if community-based is not available. This is subject to a 1-year exception if the disaster plan is actually implemented. They too also have to conduct a paper-based desktop exercise at least annually. This desktop exercise is a group discussion led by a facilitator using narrated clinically relevant emergency scenario and a set of problem statements, directed messages, or prepared questions designed to challenge an emergency plan. Additionally, you must analyze the hospice's response to and maintain documentation of all drills, tabletop exercises, and emergency events, and revise the plan as necessary. This is the section where I wanted to offer some additional clarification of requirements based on some of the regulatory preamble that offered a lot of questions. You heard me say several times during this the all-hazard risk assessment approach. What does this include? The rule indicates that it's imperative that there is an all-hazards risk assessment consistent with concepts outlined in the National Preparedness Guidelines published by the U.S. Department of Homeland Security. CMS encourages hospitals in adjoining states to work together to formulate plans to provide services across state lines in an event of a natural and man-made disaster to ensure continuity of care during a disaster. Within the regulation itself, it mentions 4 phases of emergency management to consider. The 4 phases are 1, mitigation activities to lessen the severity and impact of a potential disaster or emergency might have on health facility operations. Preparedness activities to build capacity and identify resources that might be or should be used in a disaster should an emergency occur or a disaster occur. Response to the actual emergency and control the negative effects of the emergency situation. And 4th, recovery that begins almost concurrently with response activities and directed at restoring essential services and resuming normal operations to sustain the long-term viability of the health facility. There was another question, given the requirement for community-wide collaboration and coordination of emergency preparedness plans, what entity is best positioned to facilitate this coordination? CMS asserts that since hospitals are the focal points for healthcare in their respective communities, hospitals are in the best position to coordinate emergency preparedness planning with other providers and suppliers in their communities. There is a question about what will CMS be doing to accommodate the special situations faced by rural providers. While CMS acknowledges that rural communities face challenges in emergency preparedness and cites studies that document some of the challenges and limitations, it does not, however, make any special accommodations for rural facilities. Does CMS plan to address the cost of emergency preparedness? CMS notes and that they have and continue to be sources of grant funding to state and local governments dedicated to funding emergency preparedness activities. In addition, CMS projects relatively modest startup costs at the provider level and balances these costs against the potential savings in dollars and lives that will result from effective disaster preparedness. As I mentioned at the top of the recording, CMS has estimated that your plan will take about 26 hours at around $1,424 to develop, and then an additional 80 hours total to do everything listed in the regulation. When asked, does CMS offer specific guidance in meeting these regulations, it is important to note that while CMS makes multiple references to government and private reports and websites throughout the preamble to the regulation, and offers guidance, it does not include templates or model plans or procedures that would facilitate this process. They are assuming that each provider will find its own route to compliance. So that is what guidance we have at this time on emergency preparedness. Just as a note to you all, the rule went into effect November 16th of 2016, but full compliance and implementation has to be done by November 16th, 2017. On this last slide, you have my phone number and my email address, which is jcameron@vnaa.org. If you have any additional questions about emergency preparedness or any other regulatory or policy concerns, feel free to reach out to me, and I will get back to you as soon as possible to discuss your needs. Thank you so much for tuning in, and I appreciate your attention.